So thank you very much for that introduction. And also I would just like to say thank you to East Kent for allowing me the time to make the presentation. And if there are any of my colleagues listening, welcome to you all as well. So great to see so many people. Okay, so this is a case study that I'm presenting for you. I've called it a case of mistaken identifier. I hope you think that's a good title for this. This is because rather than identity, we use identifiers in blood transfusion. So that's what I'm trying to make a play on words for. Next slide, please, Francis. Okay, so this is a case study from QEQM at Margate. We are a trauma centre. We are miles away. If you look on the map, we are right down in the corner of southeast Kent. We have a blood transfusion, a hospital blood transfusion team. We have an agreed risk-assessed major hemorrhage protocol, and this MHP activation is dependent on age and sex of the patient. So as I say, I'm looking at my notes here, we are a trauma centre. We are 4 hours away from Tooting. So if you include the packing time for the units of blood, we are actually 4 hours and 45 minutes away. We've had the MHP in place for over 14 years. I was looking at this with our transfusion practitioner, and we reckon it's more than 14 years. It is regularly reviewed and it's risk assessed through the hospital transfusion committee. We've had the male pack in place for more than 5 years. Again, we couldn't find out when we actually did have it. We looked at our change control and it was manual before then, so we couldn't find it. But we've definitely had it in place for more than 5 years and we have never had an issue. Next slide, please. So our female MHP is a female of childbearing potential. So that's somebody who's less than 50 years old or a male less than 18 years old. And we use less than 51 for our limb system so that we can be sure of capturing the right age group. Our first pack is 4O neg, K neg red cells with 2 ABFFP. And our second pack is 4O neg, K neg RBC with 2 ABFFP plus 1 unit of emergency platelets. So I just mentioned that obviously our woman of childbearing potential is less than 50 years old. So we've set it as less than 51 on our limbs. Our emergency platelets that we have available in our trust tend to be A positive, high titer negative, but in reality, it may just be whatever is currently available. That's what we've got. Next slide, please, Francis. And so we also have a male pack. This was introduced after our female pack in line with the NHSBT recommendations and guidelines. And so this pack is for a male greater than 18 years or a female over that magic age of 51 years. The first pack is 4O pos red cells plus 2 ABFFP, and the second pack is 4O pos red cells, 2 ABFFP, and 1 pack of emergency platelets. And as I say, it generally tends to be A positive platelets, but in reality, it's whatever we've got. So this pack just tends to be the fresher to O pos red cells in our bank, and that's how we allocate it. And if the MHP red cells are not used, then they are recycled when they have at least 5 days expiry left on them, so that we do not leave blood out in our fridges and then get it back with a short expiry date. So we have a very close monitoring on what blood is available as our packs. Next slide, please. So finally, we get around to our case study. So it was a Sunday. So this is a CPP shift for us. It's a skeleton staff, and we only have 1 person on a Sunday running haematology and blood transfusion combined. So it was an activation, a male, early 30s with a femoral aneurysm. We were told that they'd done a EKHUFT and it was less than 7. And so we naturally activated the male MHP. The first MHP pack was delivered to resus in under 40 minutes from the patient actually arriving. So this is, we delivered it much quicker than that once the blood bank was actually notified that there was an MHP, but we know that the patient came into resus and in 40 minutes they had already got those packs. So we love the MHP. I have to say I hark back to an era when we didn't have such a thing in place. And so we really love the MHP. No more multiple phone calls from multiple different healthcare people, giving multiple different requests on what they want and when they want it. And I always used to call it 2468. We don't know what we want, but we can't wait. And so we love the MHP now because it really controls that communication and it really puts us in the driving seat of what's going on. So that's where we are. We've got a male and we've activated our male MHP. Next slide, please, Francis. So the samples arrive in the blood transfusion laboratory. We do electronic issue, so we require 2 group and safe samples. They're all labelled correctly according to our acceptance criteria, and they're barcoded and loaded onto the blood transfusion analyzer. We look the patient up on our limb system and they are not known to our trust. We also receive full blood count, coag screen and biochemistry, so they're all received and processed. So I'm just making sure that I've got the right slide. So the BMS has issued that first pack and is anticipating issuing the second pack based on the results that we get in the laboratory. Next slide, please, Francis. Okay, so the first thing happens, 23 minutes later, we get our blood transfusion results off. And this patient turns out to be A negative with a positive antibody screen. And I've put underneath that EK because that is a word that I frequently use in blood transfusion when we need to stop, we need to recalibrate, and we need to think again. So obviously, think back to our male hemorrhage pack, we have issued the O positives. So straight away, we need to inform resus and the hemorrhage that potentially we've issued incompatible blood to this patient. 3 O-pos red cells have already been transfused at this point in time. So the biomedical scientist sets up our automated panel, which goes onto our analyzer, and they start following our SOP, which is for the investigation of a positive antibody screen. So if you just imagine as well what I said to you earlier on, our biomedical scientist is already multitasking, they are juggling their workload, they're thinking ahead, they're thinking of this problem that has arisen, and they're trying to keep their cool. So as part of the East Kent positive antibody screen investigation standard operating procedure, we interrogate SPICE. Next slide, please, Francis. Okay, so SPICE is really, really useful, and it's really excellent that we can look it up and see where these patients have been tested before. So the patient is known on SPICE and they're from another local trust. So the patient has obviously been in the area and has had samples tested at another local trust, which are now on SPICE. So remember what I said about the patient earlier on. It was a male, a young male in their 30s. We looked on SPICE and this patient is female. So this comes in, EK comes in again, this time probably with 2 exclamation marks. So we haven't got anything else to go on apart from that the patient's got a very unusual first name. Obviously for patient identification purposes, I can't share it with you, but that name would not conventionally be associated with male or female. So we didn't get any help from that. So straight away, it demonstrates how useful SPICE is because it's putting us ahead of the game in that we know that this patient is known locally with antibodies. But the patient is A-neg with anti-D, and our BMS, who's in the lab on their own at the moment, immediately starts worrying about the fact that D-pos, possibly K-pos blood, has been issued to a female in their 30s, and we all know that that is something that we would normally be avoiding. So our BMS in the lab has already now got the added stress of thinking that this is actually a female patient, not a male patient. Next slide, please. Okay, so the patient is on SPICE as A-neg, K-neg with anti-D. but it wasn't confirmed whether this is allo or prophylactic anti-D at the time, and there was no further follow-up. So this means that the patient's already got anti-D, so we're not going to be giving them, and we're not going to be exposing them to D-positive cells and giving them anti-D. But the risk is now that we could be looking at hemolytic transfusion reaction or exposure to the K antigen in this young female patient who is categorized as of childbearing potential. So again, SPICE has been very good in coming to the rescue for us. Next slide, please, Francis. So the first thing that we do is to contact resus. We withdraw the second male MHP pack, which obviously would be another lot, another 4 units of OPOS RBC. We understand that the patient has been stabilised by now and will be transferred to the sister site, which is the Kent and Canterbury site, because the patient is now a vascular patient. And they will be put in a ambulance as soon as they are properly stable and taken to another site. So the patient is compos mentis, and they are questioned with regards to their gender and to their sex. So obviously gender is what they identify as, sex is what they were born as. So are they male or female, or could they possibly be trans? So the patient confirms the gender and sex to be male, and all other ID that we've received is confirmed as correct. So we've got a case of a mistaken identifier here. So at this point in time, we know that the patient is going to be transferred, and we decide that when the patient arrives at the sister site, we will request a new group and save, because obviously on the new site, they will be performing a full serological cross-match. As we know that we've got a positive antibody screen, patient will not fall under the criteria of electronic issue. And if there was no time for cross-matching, then we decided that the patient would go straight onto the female MHP this time, not the male, because as you remember, our female pack is going to be ORH negative. Next slide, please, Francis. So now I would like to say it's the calm after the storm. The patient has been stabilised and we've got time to gather our thoughts. So it transpires that the patient has actually changed their first name and their second name several times over the years because they have had frequent encounters with the law, and has also done time at Her Majesty's pleasure. And I guess that's now His Majesty's pleasure. The patient is a known IV drug user. They've got rhabdomyolysis, which is sort of like a necrotic breakdown of the flesh around the wound, which means that there will be release of proteins in that area. And the consultants have decided that there will be a probable above-knee amputation once the patient is stabilised. So we have now got time to do a post-transfusion workup on the original site that the patient attended. All 3 red cells that were transfused are incompatible. However, there's absolutely no visible sign of a transfusion reaction. And so it's really interesting for me that the patient has actually got a really strong anti-D. We've given them 3 units of incompatible blood, and there's been no observable transfusion reaction. And that's really important for what I'm going to say later on about how we categorise that. And so the patient, as I say, has confirmed that they are male, gender and sex, and that they have had name changes. So potentially we have tested this patient in our own trust, but under a different name. Next slide, please. So just to give you a little bit more follow-up on the SPICE situation, East Kent has actually been paper 3 reports from SPICE for over 2 years now. And at this point in time, I'm going to say to you, have you checked your NHSBT paper reports for sex? It's not there. So that's a patient identifier, which is not recorded on the NHSBT paper reports. So it transpires on further investigation. As I say, this is the calm after the storm. It transpires on further investigation to that trust where the patient had been tested and referred to SPICE, that the patient had actually been incorrectly entered at SPICE as female, And of course, if you don't get a report back with the sex on the report, you've got no way of auditing this has been actually correctly entered at the NHSBT, unless you actually check against the website, and that's where the sex will be. And as I say, we love the fact that we are paper free at East Kent. I can thank my colleague Sue, who hopefully is listening to this now. She's a great driver for being paper free, and we cut and paste our reports of SPICE and we enter them directly into our LIMS, which is really useful because you don't get any transcription errors. However, this has identified something that we should all be checking, as it is one of our patient identifiers, isn't it? Okay, so next slide, please. So follow up on our patient who we have successfully kept alive and they are being stabilised and they are sent to ITU. So there's been absolutely no clinical symptoms of an adverse reaction due to the incompatible red cells transfused. The subsequent blood results did indicate hemolysis. So the patient had raised bilirubins, a raised LDH, a fall in HB, and the DAT was quite weakly positive. So it's shot reportable as a hemolytic transfusion reaction. They remained critical in ITU for 1 month. They did have an above knee amputation, and they were transfused 2 red cells intraoperatively, which was obviously cross-matched serologically and was completely unremarkable. There was no transfusion reaction and no problems with that transfusion. And I understand that the patient was discharged home in July with no further follow-up. So next slide, please, Francis. So we did that follow-up on the patient, and as I say, the patient went home unremarkable. He has gone back to his life outside of the hospital, and we've had an unremarkable follow-up. However, follow-up on my biomedical scientist. I'd just like to say that the biomedical scientist who was involved in the MHP is a really, really experienced, cool-headed bloke. And as I say, he was quite alarmed by the fact that we had issued incompatible blood to our patient. So I reassured him that he'd done absolutely nothing wrong. Based on our risk assessed male MHP, he had done absolutely nothing wrong. And I reassured him that the MHP is risk assessed and reviewed regularly and agreed by the Hospital Transfusion Committee in East Kent. And I reassured the team because, of course, people do talk, people do worry, people do share experiences, that absolutely nothing could have been done differently and nothing will be done differently. And so this was locally reported on Datix as low harm. And I questioned that with our transfusion practitioner, who was obviously responsible for raising the Datix, and she said that it was low harm because the management and the treatment plan of the patient did not change as a consequence of being transfused incompatible blood. So I find that really interesting. So last slide, please, Francis. So really, the moral of the story is audit your paper reports against SPICE, because what you get on paper might not be what's actually recorded on SPICE if we're not looking at that sex. And really, for me, we look closely at the clinical staff post MHP and the area that received that patient, and we look at the patient post MHP. But maybe for me, this highlighted to me is my biomedical scientists supported appropriately. They had quite a full-on experience with this, and the feeling of dread when they realised that actually incompatible blood had been issued, even though it was not their fault. So we spoke about this, and I pointed out to our whole team that our MHP is a measured and unavoidable risk of using the MHP is that we may have incompatibility, we may issue incompatible blood, and it's a measured and unavoidable risk that is documented in our Hospital Transfusion Committee. In 14 years of actually using the MHP, this is the first time that we've actually had incompatibility, and I think that's pretty good. So I'm definitely not saying that we want to change anything. We are very happy with our female MHP, and we are more than happy with our male MHP. And so I just wanted to really, as my conclusion, just say you're probably all aware that there are new standards of proficiency out for the HCPC, and the registration focus is now much more heavily on the mental health of the registrant. And I'm really hoping that this is because they have recognised the mental health pressures that are put on our biomedical science staff, especially those working in situations as I've just described. Thank you very much for listening.